Hi everyone and welcome to your chapter 21, Adrenal Function. And this is a continuation of all of the endocrinology chapters. So we'll start with some terms here that we'll need to be familiar with for this chapter. And so aldosterone is the first one. Aldosterone is the main mineral corticoid hormone. It is a steroid hormone that is produced by the zona glomerulosa of the adrenal cortex in the adrenal gland. It is essential for sodium conversion in the kidney, in the salivary glands, and also the sweat glands and the colon. Glucocorticoids is another term that we need to be familiar with in this adrenal function lecture. They are a class of corticosteroids, which are a class of steroid hormones. Glucocorticoids are corticosteroids that bind to the glucocorticoid receptor that is present in almost every vertebrate animal cell. ACTH stands for adrenocorticotropic hormone. This is a hormone that is produced in the anterior or in the front part of the pituitary gland that's located in the brain. The function of the adrenocorticotropic hormone is to regulate the levels of the steroid hormone cortisol, which is released from the adrenal gland. Cortisol is the next term. Because most of the body cells have cortisol receptors, cortisol affects many different functions in the body. Cortisol can help control blood sugar levels, regulate metabolism. It helps you reduce inflammation and assist with memory formulation. It has a controlling effect on salt and water balance, and it helps control blood pressure as well. CRH stands for corticotropin releasing hormone, and this is a peptide hormone that is involved in the stress response. It is a releasing hormone that belongs to the corticotropin releasing factor family. In humans, it is encoded by the CRH gene. Its main function is the stimulation of the pituitary synthesis of ACTH. Okay, so let's talk about the adrenal gland and its function. The adrenal gland is a multifunctional organ that produces steroid hormones and neuropeptides that are essential for life. So despite the complex actions of adrenal hormones, most conditions of the adrenal gland are manifested by their impact on blood pressure and also electrolyte balance. So, when should you consider an adrenal issue or an adrenal diagnosis? Well, when there's hypertension, hypokalemia, and metabolic acidosis. These are the symptoms and the clinical manifestations of hyperaldosteronism. When you see hypertension, anxiety, palpitation, dizziness, and diaphoresis, you could suspect that this could be a condition called pheochromocytoma. We'll talk about that in the next few slides. Hypertension, rapid unexplained weight gain, red-purple stretch marks, and proximal muscle weakness could signify Cushing's syndrome. Inappropriate hirsutism, virilization, and inability to conceive could signify a congenital adrenal hyperplasia. Loss of appetite, unintentional weight loss, and pigmented skin could signify primary adrenal insufficiency. Hypofunction for this is typically treated with exogenous hormone replacement. Hyperfunction, on the other hand, is typically treated with pharmacologic suppression or surgery. Okay, so let's talk about the embryology and the anatomy of this particular gland. The adrenal gland is composed of the outer adrenal cortex, and it also has an inner adrenal medulla. The cortex is derived from mesenchymal cells near the uterogenital ridge, and the medulla rises from the neural crest cells that invade the cortex during the second month of fetal development. The adult adrenal glands are shaped like pyramids, and they are located just above and medial to the kidneys. They are also known as suprarenal glands. The adrenal arterial supply is symmetric. There are axons that reach the medulla through the cortex. Glucocorticosteroids from the cortex are carried directly to the adrenal medulla via the portal system, where they stimulate enzyme production of epinephrine. And medulla projections into the cortex have been found to contain cells that also synthesize and release neuropeptides, such as vasoactive inhibitory peptide, VIP, adrenomedullin, and atrial natriuretic peptide. So let's talk about the adrenal cortex and divide that by zones. The major adrenal cortical hormones, aldosterone and cortisol and DHEAS, dihydroepiandrosterone sulfate, are all synthesized from a common precursor, cholesterol, by cells in one of these three different zones. The first zone is the zona glomerulosa, the G zone. This is what comprises the outer 10% of the adrenal cortex. This particular zone synthesizes mineral corticosteroids that are critical for sodium retention, potassium, and acid-base balance. The second zone is the F zone, or the zona fasciculata, which is the middle and comprises about 75% of the adrenal cortex. In this zone, there is synthesis of glucocorticoids that are critical for blood glucose homeostasis and also for blood pressure. And the last zone is the R zone, or the zona reticularis, and that's the inner 10%. And this is where sulfate DHEA and DHEAS is synthesized. So let's talk about cortex steroidogenesis, which is the formation of the corticosteroids. The control of steroid hormone biosynthesis is very complex, and it includes the adrenocorticotropic hormone, ACTH, and angiotensin II, AT2. This steroidogenesis occurs via substrate availability, enzyme activity, and inhibitory feedback loops. All adrenal steroids are divided by sequential enzymatic conversion of a common substrate, which is cholesterol. The adrenal cells accumulate and store LDL. Only free cholesterol can enter the steroidogenic pathways in response to ACTH. Availability of the free intracellular cholesterol is regulated by ACTH and LDL. Corticotropin-releasing hormone, CRH, is secreted from the hypothalamus in response to signals, low cortisol levels, and stress. CRH stimulates the release of stored ACTH from the anterior pituitary gland, which stimulates the transport of free cholesterol into the adrenal mitochondria, initiating steroid production. Conversion of cholesterol to pregnenolone is a rate-limiting step in the steroid biosynthesis. 6 carbon atoms are removed from cholesterol by cytochrome P450, and newly synthesized pregnenolone is then returned to the cytosol for subsequent zonal conversion enzymes. High serum glucocorticosteroids suppress the release of CRH and ACTH via a negative feedback mechanism. Cortisol is the primary feedback regulator of ACTH-stimulated hormone production in the adrenal cortex. Decreased activity of any enzymes required for biosynthesis can occur as an acquired or inherited trait. And defects that decrease the production of cortisol can also cause increases in ACTH and CRH secretion in the attempt to stimulate cortisol and lead to adrenal hyperplasia or the overproduction of androgens. The evaluation of adrenal function requires measuring relevant adrenal hormones, metabolized, and also regulatory secretories. So let's talk about some conditions of the adrenal cortex. Congenital adrenal hyperplasia. These are a group of entities that arise from absent or diminished activity of enzymes involved in steroidogenesis. The conditions vary depending on the enzyme that is affected. It causes decreased glucocorticoid and increased adrenal androgen production. The most common enzyme affected is 21-hydroxylase. In 21-hydroxylase deficiency, this is a classic. The classic presentation is seen in infants. There is failure to thrive and also low blood pressure. For this condition, the patients experiencing this need glucocorticosteroid replacement therapy. There is also a non-classic form of 21-hydroxylase deficiency, and that's mostly seen in adult women. It may be present with hirsutism, menstrual irregularities, and infertility, and these patients may need steroid during pregnancy periods. Hirsutism is when a patient has a lot of facial hair and a lot more hair all over their body than a normal person would. Okay, so remember, aldosterone is the main mineralocorticoid hormone. It is a steroid hormone that is produced by the zona glomerulosa of the adrenal cortex in the adrenal gland. This aldosterone hormone is very, very important for sodium conversion in the kidneys. It's also very important for sodium conversion in the salivary glands, also in the sweat glands and in the colon. So primary aldosteronism, as you can imagine, is a clinical situation in which there is excessive secretion of aldosterone. Okay, so this is a mineralocorticosteroid, a steroid hormone produced in the adrenal cortex and the adrenal gland that is essential for sodium conversion in the kidneys. So in this condition, there is excessive secretion of aldosterone, and it cannot be suppressed with salt or volume replacement. There is hypertension, hypokalemia, so a decrease in potassium, metabolic alkalosis, and also an increased risk of vascular disease. About 5 to 10% of patients with hypertension have primary aldosteronism. So, what's the etiology? Well, it can happen because of different reasons. There is a chance that a person can get primary aldosteronism due to an aldosterone-producing adrenal adenoma, also a unilateral or bilateral adrenal hyperplasia. There is a condition called familial hyperaldosteronism or adrenocortical carcinomas that secrete high levels of aldosterone. Also ectopic aldosterone secretions. These are all reasons why a person can experience primary aldosteronism. So, in terms of this condition, we could detect it by looking at the plasma aldosterone concentration and also the plasma renin activity, PAC and the PRA. These are both used, these are tests that are commonly used in the diagnosis of primary aldosteronism. If the aldosterone concentration is over 50 nanograms per deciliter and the PAC, PRA ratio is over 30, that is suggestive of primary aldosteronism. The laboratory results or the specimens are checked in the morning after the patient has been up for 2 hours. If they are seated for 5 to 15 minutes before the draw, the sodium intake has to be unrestricted. If the initial screening is suggestive of primary aldosteronism, confirmatory tests include an aldosterone measurement following either an oral salt load or an IV saline infusion. The laboratory evaluation is then followed by the adrenal imaging, either a CAT scan or an MRI. The presence of an adrenal mass should still prompt further testing before surgical intervention. There is a test called the adrenal venous sampling, the AVS, which is recommended to distinguish between hyperplasia and aldosterone secreting adenomas. Okay, so this is an example of a diagnostic algorithm for primary aldosteronism. Some of the tests are urinary potassium excretion, the upright PA-PRA ratio, which we just talked about. There is a test called the captopril suppression. We can also use the levels or assess the levels of 18-hydroxycorticosterone levels. Adrenal imaging by CAT scan or MRI, or the adrenal vein sampling, the AVS test. Treatment usually involves surgery. Surgery is the treatment for the aldosterone-producing adenomas, but hypertension is controlled in about 30 to 60% of patients that are treated surgically. Spironolactone or eplerenone are mineralocorticosteroids that are used for the adrenal hyperplasia condition. There is also a condition called isolated hypoaldosteronism. In this condition, this is an isolated event with insufficient aldosterone secretion. This could be due to adrenal gland destruction. Sometimes it could be due to chronic heparin therapy or after unilateral adrenalectomy. There is typically a G-zone enzyme deficiency that occurs here. And the treatment includes dietary changes and fludrocortisone, which enhances salt retention and the secretion of potassium and hydrogen. In terms of the adrenal cortical physiology, the cortisol synthesis is critical to the hemodynamic and glucose homeostasis. Exosome disorders manifest typically with high blood pressure or issues with the blood pressure and also with glucose abnormalities. Glucocorticoids maintain blood glucose levels by inducing lipolysis and by causing gluconeogenesis and storage of glucose as liver glycogen. Adrenal insufficiency is a term that describes inadequate hormone secretion from the adrenal cortex. The primary adrenal problem is where there is inadequate release of cortisol, aldosterone, and adrenal androgens. In primary adrenal insufficiency, there is reduced production of the adrenal hormones despite adequate stimulation. In secondary adrenal insufficiency, the adrenal gland function is preserved, but the stimulus for hormone release is insufficient or absent. This is the most common cause of adrenal insufficiency, which is an autoimmune destruction of the adrenal gland. Other causes of adrenal insufficiency can be infections, tumors, bilateral adrenal hemorrhage, etc. And symptoms of adrenal insufficiency include weakness, fatigue, anorexia, nausea, diarrhea, abdominal pain, and weight loss. Adrenal insufficiency can be suspected if the 8 a.m. cortisol test or the cortisol level is low with elevated ACTH levels. Cortisol levels less than 3 micrograms per deciliter in the AM is highly suggestive of adrenal insufficiency. So, in terms of the diagnosis and testing of adrenal insufficiencies, with primary adrenal insufficiency, we would perform an ACTH stimulation test. The test is performed at 8 a.m. in a fasting state. We take the baseline cortisol and ACTH levels. The patient is then given a 250 microgram dose of cosyntropin, which is synthetic ACTH, and also synthetic ACTH, and the cortisol levels are checked at 30 minutes and 60 minutes. Cortisol levels of 18 or greater suggest normal adrenal function. If this does happen, the treatment for primary adrenal insufficiency is usually a treatment with glucocorticoid and mineralocorticoid replacement therapy. For secondary adrenal insufficiency, the stimulation ACTH test may be normal or abnormal, but if secondary adrenal insufficiency is suspected, you want to perform the methyropone test or the methyropone suppression test. Patients with secondary adrenal insufficiency will have a near normal response to cosyntropin, but an abnormal response to methyropone tests. In this case, when the patient does have, and it's confirmed that they do have secondary adrenal insufficiency, the treatment is done with glucocorticoid replacement therapy. Okay, so let's talk about hypercortisolism. And we'll talk about what this condition is and some of the testing that we do, the etiology, and also the symptoms and the clinical presentation. Okay, so an overview of hypercortisolism is where there is excess cortisol production, which presents with many different clinical manifestations. Some of the common findings are obesity with sparring extremities, dorsal cervical fat pad deposition, and fat accumulation in the cheeks, giving the buffalo hump appearance or the moon face appearance to the face. Some dermatologic manifestations also occur in the skin. So there's atrophy of the skin, easy bruising, white purple striae or some stretch marks, purple stretch marks, and hyperpigmentation of the skin. In women, what's usually seen are irregular menstrual periods and some signs of androgen excess, like a lot of acne and hirsutism, so a lot of facial hair and hair all over the body. These patients with hypercortisolism are at increased risk for cardiovascular disease, DVTs, deep vein thrombosis, anxiety, and also very vulnerable to certain infections. So just to go back, hypercortisolism is caused by the overproduction of cortisol, which also signifies there's an overproduction of CRH, ACTH, and it could also be caused by an excess of adrenal glucocorticoid secretion and excess exogenous intake of cortisol. And that's what I was just going to talk about, the etiology of it. So again, hypercortisolism is caused by the excess glucocorticoid production or prolonged exogenous steroid use. It can be due also to adrenal tumors that make excess cortisol, in which case the pituitary release of ACTH is low. On the other hand, excess cortisol production can be due to elevated ACTH levels, either from pituitary tumors or non-pituitary tumors, or ectopic sources associated with lung cancer. An example of hypercortisolism is seen in a condition called Cushing's disease. Cushing's disease is when the source, it's named Cushing's disease when the source of elevated glucocorticoids, or when the source of elevated ACTH levels is the pituitary gland. This is actually the most common reason for cortisol excess and accounts for about 70% of the cases. And Cushing's syndrome has the name when cortisol excess comes from other sources. And here is an example of some of the signs and symptoms and the clinical manifestations of Cushing's syndrome. Some central obesity, so typically the fat deposition in the abdomen. There's objective weakness, some easy bruising, some spontaneous ecchymosis. There are wide red to purple stretch marks in the stomach area and also on the side by the hip area. Issues with the bones, so some osteopenia or osteoporosis, and hypokalemia as well. Here are an example of what the facial manifestations are, and also the manifestations in the extremities. There's the appearance of fat deposition in the cheeks, so it gives the patients a moon face type of look. Hirsutism, that's usually seen in women, which is excess hair seen, usually around the chin area, around the underneath the nose area. There's fat deposition in the back of the neck, which gives the person the appearance of a buffalo hump. Issues with the bone, cardiac issues, fat deposition again around the abdomen, stretch marks, very dark purple, red to dark purple stretch marks. Irregular menstrual periods are also seen in women. So women would have some of those issues. There's also bleeding issues with that are seen in the skin. So skin ulcers due to poor wound healing. So in terms of the diagnosis, there are at least 2 of the tests that are needed to be positive to determine the presence of hypercortisolism. We can do a urine free cortisol test that's collected over 24 hours. We can also do a midnight salivary cortisol test, checking the late night salivary cortisol levels, and the DST test, which is the dexamethasone suppression test. So at least of these 2 need to be positive to determine hypercortisolism. So once hypercortisolism has been established, a reliable 2-site IRMA test or immunoradiometric assay for ACTH is typically used to determine the reason for the high cortisol levels. So whether it's ACT dependent or independent, right? So whether the cause is ACTH or it's not. So if it's ACTH dependent, ACTH dependent cortisol secretion is suggested when ACTH levels are greater than 5 micrograms per deciliter. So here the source is most often the pituitary gland, but it can also be the ectopic source, such as lung cancers, pancreatic tumors, etc. So it is very important to distinguish between the ectopic and pituitary sources by using the high-dose dexamethasone suppression test. If it is ACTH independent cortisol secretion is suggested when the ACTH levels are less than 5 micrograms per deciliter. So there is two types: the ACTH dependent, which would be more of Cushing's disease, and that's when the source of the source of elevated ACTH is either, it's most likely the pituitary gland, but it could also be some other issues like ectopic issues or due to lung cancers or pancreatic tumors. But the ACTH dependent Cushing's disease is the most common reason for the excess cortisol levels, and it accounts for about 70% of cases. The ACTH independent it helps in the diagnosis of Cushing's syndrome, and this is when cortisol levels or the excess in cortisol comes from other sources. Okay, so moving on. So the gold standard for determining the source of ACTH production is the IPSS test. This is the inferior petrosal sinus sampling test. So the source of ACTH hypersecretion can be investigated by simultaneous sampling of blood from the inferior petrosal sinus and a peripheral vein. The petrosal sinus to peripheral blood ACTH ratio of greater than 2 to 3 is 97% sensitive and it's 100% specific for ACTH hypersecretion from the pituitary gland or Cushing's disease. Imaging with CAT scan or an MRI is used to localize the pituitary or the ectopic ACTH secreting tumors. The outcome for patients with Cushing's syndrome is similar for that with type 1 diabetes. So what are some treatments? Well, for Cushing's disease, there's the transsphenoidal resection of the pituitary tumor, and transsphenoidal literally means through the sphenoid sinus. So it is a surgery that is performed through the nose and the sphenoid sinuses to remove a type of pituitary tumor. And so this transsphenoidal surgery can be performed with an endoscope and a microscope or both of them. So this has cure rates of 80 to 90% that can be achieved with microadenomas, so if the tumor is very small, and cure rates of 60% when there are macroadenomas, which are tumors that are greater than 1 centimeter in size. And for Cushing's syndrome, the surgical resection would be the first step in the management, but we can also use adrenal enzyme inhibitors, ACTH secretion suppressors, and glucocorticoid receptor blockers. All right, so now let's talk about some of the adrenal androgens that are produced by the adrenal glands. So androgens are produced as byproducts of cortisol syntheses that are regulated by ACTH. DHEA, dihydroepiandrosterone, and DHEAS are precursors to more active androgens and estrogens. Adverse effects are caused by the conversion to active androgens in the adrenal and peripheral tissues. So in hair follicles, sebaceous glands, genitalia, adipose, and prostate tissue. So although men derive less than 5% of their testosterone from the adrenal or peripheral sources, women rely on the adrenals for about 40 to 65% of their daily testosterone production from precursors. Adrenal androgen production peaks in young adults and declines with age. So, excess. So, androgen excess causes ambiguous genitalia in female infants and precocious puberty in children of both sexes. Ambiguous genitalia is basically a rare condition in which an infant's external genitals don't appear to be clearly either male or female. In a baby with ambiguous genitalia, for example, the genitals may be incompletely developed, or the baby may have characteristics that belong to both sexes, male and females. And precocious puberty is when a child's body begins changing into that of an adult, which is the process of puberty, but this is happening too soon. The process of puberty is basically happening way too early. So some of the symptoms of androgen excess in boys can be presented as penile enlargement, hair growth, and precocious puberty. And in girls, again, the ambiguous genitalia that's usually seen as they are infants, hirsutism, acne, clitoromegaly, short stature, and precocious puberty as well. In women, there's infertility, hirsutism, acne, male pattern baldness, menstrual irregularities, and fertility. In men, infertility and decreases in muscle mass, hair growth, the size of the testes, testosterone production, and spermatogenesis. So we would detect this with high levels of the DHEAS and the DHEA. Also, you can look at the testosterone levels. So these are the precursors. DHEA and DHEAS are the precursors used in the androgen production. And again, androgens are produced as byproducts of cortisol syntheses that are regulated by ACTH. Treatment would warrant surgical removal of the tumors or exogenous DHEA. Okay, so the adrenal medulla is the inner part of the adrenal glands, and it secretes catecholamines directly into the circulation in lieu of transmitting messages via afferent axons. Catecholamines regulate the body's sympathetic response to stress and act as the first responder to stress within seconds to promote that fight or flight response. It also increases cardiac output and blood pressure, diverts blood to the muscle and the brain, and immobilizes fuel from storage. So how does this come about? The adrenal medulla, well, sympathetic cells arise from the primordial neural crest stem cells, which differentiate into sympathoblasts and pheochromoplasts. How do what is the production of catecholamines like? Well, norepinephrine and epinephrine are synthesized by conversion of phenylalanine substrates in a tightly regulated manner. Catecholamines are degraded in three ways. There is either the reuptake into secretory vesicles, uptake into the non-neuronal cells, mostly liver cells, and also degradation. Two enzymes, the COMT and the MAO, produce metabolites from free catecholamines, and metabolites and free catecholamines are filtered into urine and they are excreted. We can measure catecholamines in the urine and in the plasma. Urine catecholamines are assayed in liquid chromatography, fluorometrics. We can also do LCMS or mass spec, and using a 24-hour level in urine is actually more accurate. So, pheochromocytoma and paraganglioma are two conditions that are very rare and that have to do with the adrenal glands. So these are rare catecholamine secreting tumors that arise from the chromaffin cells. Tumors from the adrenal medullas are called the pheochromocytomas, and tumors that are from the sympathetic ganglia are called paragangliomas. It is very important to distinguish between both of these because of the implications that are related to the risk of malignancies and also for genetic testing. There's also a condition that combines both of them, pheochromocytoma paraganglioma, PPGL, which is when both of these conditions are combined. So this is rare. It occurs in 0.2 to 0.6% of patients with hypertension in the 4th and 5th decade, and they can be either female or male patients. 98% of the tumors are within the abdomen. 85% originate from the adrenal gland. 70% of those are sporadic tumors. 30% have syndromic presentation. So these tumors are diagnosed in 4 different clinical situations. Patients that present with the symptoms, they can be diagnosed during an evaluation of an adrenal mass. They can be diagnosed during a screening of patients with related syndromes and or screening of family members that are diagnosed with PPGLs. The symptoms are typical of a classic triad. Patients get palpitation, headaches, and also lots of sweating. Other symptoms that are not as specific but are also related to these tumors are pallor, hand tremors, shortness of breath, weakness, fatigue, and also panic attacks. So the diagnosis of pheochromocytoma are listed here. We can use fractionated metanephrines and catecholamines in a 24-hour collection, which is the best test for diagnosis. We can use the total plasma catecholamines and urine metanephrines, which is the most sensitive screening profile. We can use the plasma metanephrines by HPLC or RIAs. We can use the urine metanephrines, mostly, possibly the most sensitive urine test available for that. Serum chromogranin A and plasma catecholamines can be tested. We can also test the clonidine suppression test or radiologic localization by a CAT scan or an MRI, also PET scans. The treatment involves surgery following appropriate medical preparation. There is always, a high risk here because of surgical procedure, which is removal of a tumor. Typically, catecholamines fall to normal within a week of resection, and preoperative alpha blockade is usually recommended. Patients with familial pheochromocytomas are more likely to have a recurrence of the tumors, but long-term monitoring is indicated in all patients. There is a condition called adrenal incidentaloma. An incidentaloma basically is an adrenal mass that's typically greater than 1 centimeter in size, in diameter, that is found incidentally in a CAT scan or an MRI or an ultrasound imaging that they have done in the patient's abdomen. An autopsy study report frequency of adrenal adenomas is about 9%, and the prevalence increases with age. A workup requires biochemical testing to evaluate for hyperfunction and hypofunction and imaging to see the tumor characteristics. All lesions should be assessed for malignancy or hypersecretion. The size of the nodule is important since 90% of the adrenocortical carcinomas are greater than 4 centimeters. The smaller the size of the tumor diagnosis correlates with a better prognosis. So the smaller, the better the prognosis will be. Surgery should be considered if the adrenal mass is cancerous, autonomously secreting cortisol, aldosterone, or catecholamines. And if the tumor is 4 centimeters or greater in diameter, or if the tumor is growing. That is the slide for adrenal incidentalonoma. So these are just examples of the different types of tumors that can arise from the adrenal glands. And that ends your lecture. Thank you very much. And please let me know if you have any questions.